Good morning, I am Dr. Preeti, Associate Professor from the Department of Obstetrics and Gynecology. Today I am going to talk on fibroid uterus. The fibroid uterus is an important topic when it comes to both the exam point of view and the clinical point of view. The exam point of view, we may have questions, essay questions and short notes on fibroid, and clinically a long case can be from fibroids. And during routine clinical practice also, fibroid is a common condition which the patients will present with, and we should be able to manage the patients with fibroid uterus. So fibroids are also known as myoma, leiomyoma or fibromyoma. Fibroid is the most common benign neoplasm in the uterus with an incidence of 20 to 40% in the reproductive age group. So there are various risk factors affecting the growth of the fibroid. So increased risk is seen between the ages of 35 to 45 years in nulliparous women or women with low parity, women with an ethnic background coming from belonging to the black women, women with a strong family history, obesity, early menarche, diabetes and hypertension. Increased parity is a low risk for fibroid. Other low risk factors are exercise, increased intake of green vegetables, progesterone only contraceptive pills, and cigarette smoking. Coming to the etiology of fibroid, fibroids arises from the smooth muscle cells of the middle layer of uterus, that is a myometrium. The exact etiology is not known. Monoclonal cell origin, that is cells arising from a single cell, is confirmed by G6PD studies. There is a definite genetic basis, and various growth factors like epidermal growth factor, insulin-like growth factor, transforming growth factor beta are all recently implicated in the development of a fibroid. Estrogen, though it is not proved for causing the fibroid, it is definitely implicated in the growth of the fibroid. On gross appearance, fibroids appear as multiple discrete, spherical, pinkish white, firm capsulated masses protruding from the surrounding myometrium. The growing fibroid compresses the surrounding myometrium, leading to the formation of a pseudocapsule giving it the distinct outline. On microscopy, they are non-striated muscle fibers arranged in interlacing bundles of varying size and running in different directions, giving it a whorled appearance. Various amount of connective tissue is also intermixed with the smooth muscle fibers. Fibroids are classified based on the Figo classification, which ranges from 0 to 8. So 0, 1, 2, 3 stands for submucosal fibroid, where 0 is the pedunculated intracavitary fibroid. 1 stands for a submucous fibroid with less than 50% intramural component, and 2 stands for an submucosal fibroid with more than 50% intramural component. 3 stands for an intramural fibroid with contact with the endometrium. 4 stands for an intramural fibroid. 5, 6 and 7 stands for subserosal fibroid, where 5 is for subserosal fibroid with more than 50% intramural component, and 6 stands for subserosal fibroid with less than 50% intramural component. 7 is for a pedunculated subserosal fibroid, and 8 is for other kinds of fibroids like cervical fibroid or parasitic fibroids. Most common presentation is they do not have any symptoms. 30 to 50% of the patients present with abnormal uterine bleeding. Abnormal uterine bleeding is due to the increased surface area of the uterus due to the presence of fibroids, increased vascularity, thinning and ulceration of the overlying myometrium, endometrial hyperplasia secondary to the hyperestrogenism, venous obstruction, and interference with uterine contractions. Abnormal uterine bleeding is more common with submucous fibroid, but it can also occur with all types of fibroids. There can be features of anemia like easy fatigability because of the excess blood loss. One third of the patients present with pelvic pain and backache. Acute pain in fibroids occur due to torsion of the pedunculated fibroids, infections, expulsion, red degeneration, and vascular complications. Fibroids present with dysmenorrhea, that is pain during menstruation. The dysmenorrhea can be both spasmodic as well as congestive dysmenorrhea. Fibroids can also present with pressure symptoms, which include urinary symptoms like urgency, frequency, urinary incontinence, and urethral obstruction. Bowel symptoms like constipation, intermittent intestinal obstruction. Some patients with a large fibroid present with abdomen distension and a lump in the abdomen. If there is a rapid growth in fibroid, it is probably due to the red degeneration occurring in pregnancy, or it can be due to malignancy. 2 to 10% of the patients present with infertility. Infertility is caused by anovulation, irregular cavity interfering with sperm transport, and endometrial changes which are not conducive for the reception of the fertilized ovum. On general examination, the patient has clinical signs of anemia because of the prolonged heavy bleeding. On perabdominal examination, the uterus is mostly more than 12 week size. The uterus feels firm, nodular. It arises from the pelvis and the lower limit cannot be reached. It is a well-defined swelling which is mobile from side to side, but it is not mobile from above downwards. The swelling is usually non-tender, dull on percussion, and there is no free fluid in the abdomen. On pervaginal examination, the uterus is enlarged and it is nodular. Pervaginal examination helps it to differentiate from the ovarian mass. So in an ovarian fibroid uterus, the uterus is not separately felt from the fibroid. Movements of the cervix are transmitted to the tumor, and a definite groove is not felt in a fibroid uterus. So the most common investigation is ultrasound. So on ultrasound, fibroids appear as well-defined hypoechoic lesions. If the fibroids are very old, they may show a peripheral calcification with distal shadowing. So on ultrasound, fibroids need to be differentiated from adenomyosis. Adenomyosis presents as a diffuse lesion which is less echodense and with disordered echogenicity. The other investigations include hysteroscopy, which is helpful in diagnosis of submucous fibroids. Saline infusion sonography again helps us to differentiate between submucous and intramural fibroids. So MRI is also an investigation to diagnose the site and size of the fibroids. Now coming to the management of fibroids, most asymptomatic fibroids do not require any specific treatment, especially if their size is less than 12 weeks. Also, expectant management is done for patients nearing menopause. However, the patients need to be on regular follow-up for every 6 months. And every 6 months, a routine pelvic examination is to be done and ultrasound is to be done to compare the growth of the fibroids. So, medical management is not a definite treatment for fibroids. If the patient complains of pain, the pain is managed by giving NSAIDs, especially mefenamic acid. The blood loss can be reduced by giving tranexamic acid. Medical management is given to reduce the size of the fibroids preoperatively. The common medicine treatment in medical management is GnRH analogs, antiprogestrogens using mifepristone, androgens like danazol and gestrinol. The commonly used GnRH analogs are goserelin, triptorelin, and leuprolide. GnRH analogs reduce the size of the fibroids by 20 to 50%, reduces bleeding, and increases the hemoglobin percentage. They reduce the blood loss during surgery, helps in converting the hysterectomy into myomectomy. Also, they help in converting the abdominal hysterectomy into vaginal hysterectomy. Also helps in hysteroscopic resection of submucosal fibroids. However, they also have certain disadvantages like high cost. They have hypoestrogenic side effects like osteoporosis. The effect is reversible, that is, once the treatment stops, the fibroid regrow again. Rarely, because of degeneration, there can be increased bleeding. And following GnRH analogs, there is difficulty in enucleation of the fibroids during surgery. Another medical management which is done nowadays is mifepristone. It is used in dose of 5 to 10 milligram. It helps in reducing the volume of the fibroid by 25 to 70%, and it has no effect on the bone mineral density. So coming to surgical management, the two common options are hysterectomy and myomectomy. Hysterectomy is commonly done in patients who have finished their family and they are not interested in retaining the uterus. So the types of hysterectomy include abdominal hysterectomy, vaginal hysterectomy, laparoscopic assisted vaginal hysterectomy, and total laparoscopic hysterectomy. Myomectomy, the options are abdominal myomectomy, vaginal myomectomy, hysteroscopic myomectomy, and laparoscopic myomectomy. Coming to abdominal myomectomy, before going for myomectomy, there are certain factors which have to be considered. First and foremost, we need to take a consent for hysterectomy. Blood should be matched and reserved and kept ready. Pap smear and endometrial sampling should be done to rule out cervical and endometrial cancer. Medical and mechanical means should be used to control the blood loss. Using a bonus myomectomy clamp or a rubber tourniquet or manual compression in the isthmic region, or using a vasopressin 10 to 20 units diluted in 100 ml saline, which is infiltrated before starting the incision. Going to the procedure, the incisions are kept minimal, preferably a single midline incision, either a vertical incision in the lower anterior wall, and through the single incision we have to remove as many fibroids as possible using secondary tunneling incisions. And after these fibroids are removed, all the dead spaces should be meticulously closed, proper hemostasis should be obtained, and multiple small fibroids can be removed en bloc by wedge resection. And following the removal of fibroids, there should be measures taken to prevent adhesions. The newer modality for treatment of fibroids is uterine artery embolization. It is done by an interventional radiologist. The catheter is passed retrogradely through the right femoral artery to reach the bifurcation of the aorta, which is then negotiated down to the opposite uterine artery first. Polyvinyl alcohol particles or gel foam particles are used for embolization. Uterine artery embolization helps in reducing the size of the fibroid by 60 to 65%, and 80 to 90% of the patients have improvements in menorrhagia and pressure symptoms following the uterine artery embolization. So this is a picture showing the entry of the polyvinyl particles which are injected retrogradely through the femoral artery. Thank you. At the end of the session, we'll just summarize what we have gone through. So we have talked about what is a fibroid, what is the etiology for a development of fibroid, what are the risk factors, what is the clinical presentation, what are the symptoms the patients will present with, what are the findings we can see, elicit, and how do we go about investigating a case of fibroid, whether we have to start the patient on medical management or surgical management, and what are the surgical options for managing the fibroid. Thank you.